Thank you very much.
She is also adjunct lecturer at the Northwestern University, Chicago, USA, where she previously was a research fellow in medical retina. She is the author and co-author of numerous scientific articles and book chapters. We are very lucky to have her here in this All India Ophthalmic Society conference. Welcome, Dr. Marion.
Thank you very much for this kind introduction and this kind invitation. I'm really happy to be here today. Actually, my talk will stand out a little bit from the others. I won't show any videos. I was asked to talk about OCT angiography, guided treatment in AMD-related, exudative age-related macular degeneration. But anyway, I hope you will enjoy it. So I will just give you a brief overview. I will talk about a little bit about the CNV detection using OCTA. I will just talk a little bit about the pitfalls when you evaluate CNV using OCTA, the activity signs in OCT angiography, and changes under anti-VEGF treatment, and also the usage of OCTA to validate the absence of CNV. And last but not least, I will talk about the hot topic, subclinical CNV. Before we start to guide our treatment according to OCTA, we have to see how good it is in detecting CNV at all. So the detectability using OCT angiography really varies among the studies and ranges about 50 to 90% when you only look at the OCTA and don't look at the B scans of the spectral domain OCT. And the main point is here that the detectability depends on the CNV type. So type 2 is most easily detected using OCTA, whereas type 1 is a little bit harder, and the hardest lesion to detect is definitely type 3 and the RAP lesion. Also, in terms of the evaluation of the lesion size, type 1 and 2 are easy to measure, whereas the mixed type is a little bit harder. And again, the RAP lesion is the most hardest lesion to detect the lesion size, followed also by PCV and now so-called the aneurysmal type 1 neovascularization. Usually when you look at the OCT, you perform a scan, and usually the CNV pops up right away. In some cases, you're maybe not sure whether there is a CNV or not, especially if you haven't looked at a lot of OCTA scans yet. You may be not sure. And in terms of this, there are a couple of things you can do to make you feel sure whether there is a CNV or not. And the first one is projection artifact removal. So this is a slab of the outer retina and chora capillaris, and you may not be sure, is there something, is nothing here? And if you do projection artifact removal and get rid of the vessels above, you see that there's actually no feeder vessel, there's no CNV, and it's just a geographic atrophy here. The second thing you can do is look at different slabs. So instead of looking only at one, you can look at the chora capillaris slab, to the outer retina chora capillaris slab, or even at the RPE fit slab. And based on this, you will see the differences and you can pick up the lesions, yeah? Like here, for example, when you look at the outer retina chora capillaris slab, it looks completely different to the chora capillaris slab. And in the chora capillaris slab, you can easily see that there's no CNV present and rather geographic atrophy. Here you can see the different slabs. If you're still not sure, you can do manual alignment. Usually the alignment of the software works very well in normal eyes. However, the more diseased an eye is, the more misalignment you will have. And if you look, for example, at this is before manual alignment, and this is after manual alignment, and this looks completely different. Yeah? Actually, I have to say that the first one looks more intriguing and more you better see an illustrated geographic atrophy compared to after the manual alignment, but nevertheless, sometimes it's a helpful tool to really be sure whether there's CNV here or not. So to summarize, projection artifact removal, manual alignment, and look at different slabs. And if you do that, you can be quite sure that you won't miss a CNV here. I've just talked about that it's sometimes hard to differentiate geographic atrophy and CNV in OCT angiographies because of the anterior displacement of the larger choroidal vessels in the atrophy. And it's just, you have to keep it in mind that it is possible, yeah? And usually if you know that the choroid follows a linear pattern, in contrast to CNV, which has an irregular pattern, you can be quite sure whether it's a geographic atrophy or a CNV. And again, if you're not sure, use the artifact removal, check the alignment, and evaluate in different slabs. So now we found the CNV. What is about activity? Can we just say, based on OCTA, whether a lesion is active or not active? So when you look at this OCTA, what would you say? Is it active or inactive? Any ideas? Okay, we see here it's a very dense net configuration, and you can see here this liver subretinal fluid. So you can see here this dense net configuration, a lot of anastomosis, this lacy veal configuration, so this is definitely an active CNV lesion. What about this one? Any ideas? Yeah, right, inactive. So you can only see here the feeder vessel and nothing else anymore. So this is definitely an inactive eye and only has subretinal fibrosis, no intraretinal and subretinal fluid present. Another example, which may be a little bit more challenging, active, inactive. You can see here at this area there's geographic atrophy. You see some overlying intraretinal cysts. They may be degenerative, they may be active, rather they're more degenerative, we don't know. But you have this lesion here, which corresponds to the lesion here, and there may be still some activity, and maybe this cyst here maybe still shows some activity in this lesion. Again, another example, active, inactive. You still see only the feeder vessel here, only subretinal fibrosis, no activity. And the last example, what would you say, active, inactive? Based on the previous picture, I would say inactive. But when you now look, you see there's no CNV at all, so this was a geographic atrophy patient. So that's what I said, you have to be really careful not to misinterpret geographic atrophy from CNV lesion. So we have seen activity corresponds to a certain presentation. So if you have really a dense net configuration, lacy wheel, or C-fan branching vessels, or vascular loops, peripheral arcades, or a lot of anastomosis, this is a sign for activity, and you can be quite sure that this lesion is still active. Whereas, for example, if you have a loose net configuration or just a feeder vessel, this lesion will be inactive. And of course, this feeder vessel, this won't go away, so this will stay there forever. What about the changes under anti-VEGF therapy? Do we see any changes when you look directly at the lesion? So when we look at the short-term changes, there is a definite decrease in the vessel density under anti-VEGF treatment, and you can see these changes already 24 hours after injecting anti-VEGF. However, if you want to see, just based on the presentation on OCTA, whether this patient will be a good responder on anti-VEGF or rather a bad responder, this is so far not possible, or at least we didn't find yet any significant differences and changes here. However, when we look at the long-term changes under anti-VEGF, at least in type 1 lesion, this is very interesting because the majority of eyes show an increase in CNV area after 1 year of anti-VEGF treatment. And only a minority of the patient does 15%, so shrinkage of the CNV lesion area. I mean, this is nothing new. If you perform a fluorescein angiography of these patients 2 years under anti-VEGF treatment, you will see that the lesion is larger than from the beginning. Or, for example, if you have initially a type 2 lesion and you perform a fluorescein angiography after 2 or 3 years, this lesion will present as a type 1 lesion. So this is actually nothing new, but it's just a nice and fast way to illustrate it, and we can learn from it, and we don't know yet what it really means. So do these patients show an increase in the size need more treatment or not? So far we don't know, and I think we have to follow this to really get an answer here. It's also very helpful to verify the absence of a CNV. So, for example, this was a patient with a cirrhose PD, and he had some sliver of fluid on the left and right side. Of course, you can perform the fluorescein angiography. You will find a pooling here. You may be not sure, is it only pooling? Is it already a little bit leakage in the late phase? You can just perform the OCTA very fastly, and you can rule out the CNV here. Again, another case which has drusen in both eyes and in both eyes sliver of subretinal fluid. You may not be sure, is there something, is there not something? You just make an OCTA and you can exclude the CNV here. Another special way how AMD can present where you may not be sure what it is, you can have a RPE aperture after drusenoid or in the course of drusenoid PD, and this presents really very strangely when you only look at a fluorescein angiography. You see this large area of pooling. You may be not sure what is it. In the OCT, you see the subretinal fluid, but no RPE left here. And if you perform the OCTA here, you can be quite sure that there's no underlying CNV, and you can watch this patient, which actually has quite a good visual acuity because the photoreceptors are left. And last but not least, the topic of subclinical CNV. So actually, this is CNV. We found lesions, CNV lesions, sitting below the RPE, but no intrasubretinal fluid. So this is nothing new. So when we performed the ICG in the earliest days, we also found in a couple of patients these hyperreflective, hyperfluorescent plaques sitting there. And we knew there is a CNV, but of course we didn't perform ICG on a timely basis, on a timely manner, so we found it and we just forgot about it. Now that we have OCT and it's very easy to follow these lesions, they become very popular again for us, and we just observe them. And the question is, if a patient has this subclinical CNV, is he more prone to show exudative AMD, or how often do we have to look and observe the patient to make sure that we catch the CNV early enough and in the earlier times? And if you look at the patients who have a CNV in a fellow eye, about 10 to 18% of these patients show this subclinical CNV in their other eye. As previously said, they correspond to these ICG plaques, and they also correspond to this double layer sign. So if you have this undulating RPE, you should be very suspect that there is some lesion sitting below. And interestingly, when we observe these patients, and these lesions grow over time, so they don't have to become wet, but they grow. And if you have a patient who has intermediate AMD in one eye and CNV in the fellow eye, 18% will develop a subclinical CNV after 2 years, and 22% will show exudative AMD. So as I said, we really don't know yet what to do with these findings, and whether it would be beneficial to treat the patients before they get wet, or if you have to observe them on a monthly basis, or on a 3-monthly basis, or on a 6-monthly basis. So this is why we are now performing multi-center trials, including 300 of these kind of patients, and following these patients to really see what's happening. So I can conclude that OCTA is a valuable tool to detect CNV and AMD, to verify the absence of CNV. It shows characteristic activity signs in OCT angiography, and as previously said, we did longitudinal larger trials to assess the impact of the subclinical CNV, and also to assess the impact of the CNV growth under the anti-VEGF therapy. Thank you very much.